Minimal residual disease is becoming more and more important in the management of our patients with multiple myeloma. And there are some reasons. First, because we have many new combinations that are resulting in a high overall response rate and especially very high complete response rate. Now we can reach up to 50% of complete response rate in the upfront setting. And we know that in spite of complete response is also a good surrogate marker predicting progression-free survival and overall survival, there is not any plateau phase in neither time to progression nor overall survival. And this is the reason why we need to evaluate the complete response in depth, and we have to go to evaluate the minimal residual disease outside of the bone marrow through the use of PET-CT, but also inside of the bone marrow using next-generation flow or next-generation sequencing. But an important message is that we have to evaluate minimal residual disease with a high sensitivity level. And this has been clearly demonstrated in prospective trials conducted by both Spanish and French myeloma groups, and when we use either next-generation flow or next-generation sequencing with a sensitivity level of at least 10 to the -6, we are able to identify a subgroup of patients in which the outcome is excellent. So the final objective would be our myeloma patients to reach minimal residual disease inside and outside of the bone marrow, and I think that we are going to identify patients that can potentially be cured.